Listen now to a talk David Holmes had with Dr. Michael Weber, professor of medicine at State University of New York Downstate in New York City. They cover uncontrolled hypertension, prevalence, prognosis, and treatment. Why is all of a sudden there is such incredible interest in this? Why would that be?
There wasn't a great deal of interest until about 4 or 5 years ago, when a group of cardiologists got involved in a new procedure for treating hypertension called renal denervation, where you ablate the renal nerves, reduce signals to the kidney, and that can reduce blood pressure quite effectively. And they said, wouldn't this be a great treatment for people whose blood pressure can't be controlled with drugs? Great idea. Didn't quite work out the way they expected. And the reason it didn't work out is, yes, they were successful in ablating or severing the renal nerves by putting catheters into the renal artery and applying energy across the walls of the artery and severing the nerves. That was all terrific. The fact is, treatment-resistant hypertension or uncontrolled hypertension is a bit more complicated. For a start, we don't even quite know what its prevalence is. According to the Haynes data, roughly 12 to 13% of people being treated for hypertension. But many of us believe that, if anything, is a bit of an exaggeration.
So then, what are the diagnostic criteria to label in a chart uncontrolled hypertension?
The simple answer, and I don't really agree with it, but let's start with what the guidelines committees have said. If you have a patient who is on 3 well-selected antihypertensive drugs that you believe the patient is taking, and their pressure still remains above the target, which is usually 140 millimeters of mercury systolic, then they have, in quotes, treatment-resistant hypertension. There's a big problem with that, David. First of all, if instead of doing conventional office blood pressures, you were to do ambulatory blood pressure monitoring, which is a very effective and now very available technique in this country, and in some other countries it's actually a mandatory way of evaluating hypertensive patients, you would discover that at least a third of these patients really do have normal blood pressure. It's only in the doctor's office, the so-called white coat hypertension, that makes them look as though they're resistant. Then it gets even more fascinating, because as doctors, we never know whether a patient is really taking their medications, so-called compliance, or some people call it adherence. And even when patients swear in a stack of Bibles they're taking their medicines, even when we're convinced they're taking their medicines, the fact is they very often are not. And there have been a couple of very elegant publications where patients' urine has been examined for the presence of drugs they're supposed to be taking. It turns out, amazingly, that about a third of people who swear they're taking medications are taking nothing at all, and about 80% are taking less than they're supposed to be taking. So between white coat hypertension and poor compliance, you have reduced treatment-resistant hypertension by about 60-70%. If you now go ahead and see who's got secondary hypertension, and we're discovering, David, that hyperaldosteronism, excessive levels of aldo, are much more common than we used to think. There, we get a number of people under control simply by giving them spironolactone or something like that. Perhaps even more common, though a little harder to define, are people with obstructive sleep apnea. That may be a cause of all of this. People who are taking drugs that interfere with their blood pressure medicines. The most common culprits, non-steroidal anti-inflammatory agents that most of our middle-aged and elderly people are taking in fairly large amounts.
Religiously.
Religiously. Exactly.
There's not a compliance issue with those.
Yeah, blood pressure is a bit of an ephemeral idea, but when your hips are hurting, your knees are hurting, absolutely. So that's a big issue as well. Again, as you subtract and you subtract, my belief, David, is that instead of it being 12 or 13% of treated hypertensive patients, the reality is that it's more like 1%. So it's a pretty rare diagnosis.
Tell us then, there are some concerns that it may be more of a problem depending upon racial distributions. So, for example, one might say it could be, this is for an example, that Lutherans have more trouble with hypertension that's uncontrolled. That's just an example.
either gender or racial issues that we need to think about as we make a diagnosis of uncontrolled hypertension?
There are some rough generalizations. Women overall are more reliable when it comes to taking medicines than men. And if you look at ethnicities, certainly the experience in California has been that very often men of Hispanic backgrounds are not particularly well disposed to taking medicines. It may be a cultural issue rather than anything else. So some of those things are fairly helpful. What's interesting is that uncontrolled hypertension is roughly the same in black and white patients. And that's because the black community is very, very aware of hypertension, because black people with hypertension are, if anything, more vulnerable than whites to the bad results of hypertension, to the strokes, the heart attacks, and particularly the kidney failure. So there's a very strong awareness in the African American community about the importance of blood pressure control. So despite that, they don't do much better than whites, but at least they work harder at it.
Okay. So we've talked about the fact that there is less prevalence than we used to see in the patient who is truly resistant. What's the prognosis and what are the potential treatment options in those patients that, even though they're taking the 3 medications that they're supposed to take, it still isn't controlling it? Can you talk about that?
Yes, the answer, unfortunately, is not a happy one. People whose blood pressure, despite the best attempts to treat it, remains above 140 as compared with those who can come down to below 140. Those people are about 50% more likely to have a significant event, a stroke, myocardial infarction, heart failure, more rapidly advancing renal disease. All of the things we worry about are more prevalent in people whose blood pressures can't be controlled. So yes, there is a cause for concern, and no, we don't as yet have a definitive therapy for it. Maybe renal denervation could be an answer for some people. I think renal denervation is a great technique, and I think it's got a very strong and exciting future. But maybe treatment-resistant hypertension is going to take a little more thinking as we figure out how best to deal with that.
So is it possible that then, for example, in the field of renal denervation, we just took the wrong patients? They didn't really have resistant hypertension. Maybe it would work truly in the resistant hypertension group, or maybe it would work in the patients that are just newly diagnosed with hypertension and maybe prevent them from needing to take 3 medications. Talk a little bit about that, because it's very controversial and there are new studies coming.
You're absolutely right, Dave. And actually, your question is very perceptive, because I personally believe that renal denervation might be an ideal treatment for the young, newly diagnosed adult with hypertension, because an effective strategy that lasts a long time and isn't dependent on remembering to take pills has the chance of altering the lifelong vascular history of that person. You know, what frightens me about hypertension, if you look at young children with higher than average blood pressures, we're already seeing evidence for left ventricular hypertrophy, stiffening of the arteries. If your vasculature is already being affected at that young stage, what can we do to make a real lifelong alteration in the natural history of this condition? So your question is absolutely on target. And maybe treatment-resistant hypertension could be a target for renal denervation, but probably the easiest target, and I know it sounds a little counterintuitive, are people who are not very compliant with taking their medicines. It's no good us standing on a soapbox and preaching morality and saying if you don't take your pills, you deserve to face the consequences. The fact is, we all pay the consequences, right? Because if someone has a stroke, God forbid, with resulting incapacity, we're going to be looking after that person at very high rate, very high cost for a long period of time. So rather than seeing poor compliance as some sort of a sinful deviation, we should see it as perhaps an opportunity to give these people a treatment that will provide them with long-term protection.
Terrific. As we begin to wrap up, we are always looking for those pearls of wisdom, those things that summarize what we have done. How would you then put this together in the field of quote-unquote uncontrolled hypertension?
I think there are 2 ways we can make a simple impact, particularly in the clinical practice setting. First of all, to recognize that there's a better than 1/3 chance that this patient in front of us with apparently resistant hypertension may have a normal blood pressure at the moment they leave the office. We can either do 24-hour monitoring, or more simply, we can get them to measure blood pressure at home. And if someone can come in and show me that using a good, reliable, automated device that you can now buy very inexpensively, they have normal pressures at home, I'm willing to accept that. I think that's good information. And the other thing, and this is more difficult, David, but we have to make the effort, the real answer is getting people to take their pills. You have to recruit the spouse, get the wife to work on the husband at home. That's often effective. And let them know that you're not totally persuaded by their claims to be taking their medicines. Have them bring in their pill bottles, make sure they're renewing prescriptions, all the little tricks we've learned over the years in doing clinical trials, just to make sure that people are taking medicines. I think in the end, we can make some good inroads, but there's still a lot of work to be done.
That is absolutely tremendous. I'm always reminded of the wonderful quote that is relevant to this, that willpower lasts 30 days and is soluble in alcohol. And maybe that's the bottom line for drug-resistant hypertension. Michael, thank you for being here.
Thank you, David.